Cerebral aneurysm is treated by clipping or coil embolization. Generally, selection of the suitable treatment is carried out based on the location, shape, and size of the aneurysm. However, when limiting invasiveness is considered, coil embolization is the overwhelmingly favorable choice. With the development of various devices related to the technique, the effectiveness of coil embolization has been increasing, along with the frequency that it has been, and will continue to be, selected for use in the treatment of cerebral aneurysm. Embolization has become the first choice for the treatment of cerebral aneurysm at Tokyo Medical University Koshigaya Hospital in Saitama Prefecture, Japan. Coil embolization is used more frequently than clipping by a ratio of 2:1, with clipping being adopted mainly for cases of aneurysm in the middle cerebral artery. Meanwhile, all aneurysms in the posterior circulation are treated with embolization. In cases of aneurysm in the anterior communicating artery, the cases in which treatment selection is most difficult, embolization is chosen more often than clipping by a ratio of 2:1. In 3 cases of aneurysm in the ACOM at our hospital, coil embolization was carried out with a double balloon-assisted technique. We will hereby present one of these cases.
The patient was a 52-year-old woman whose ACOM aneurysm was identified incidentally. The neck of the aneurysm was in the left A1-A2 junction, and the right A1 segment was hypoplastic. The aneurysm was 5.2 times 5.0 times 4.8 millimeters in size, with a broad neck. Because of the broad neck, balloon-assisted coil embolization was selected as the treatment in order to preserve the anterior cerebral arteries. 5 days prior to surgery, the patient was administered dual antiplatelet therapy. Under general anesthesia, a 6 French shuttle sheath was placed in the left internal carotid artery via the right femoral artery. 5,000 units of heparin were administered intravenously with ACT extended up to 300 seconds. Biplane contrast imaging was carried out and the working angle was determined. A visual monitor using iPilot was utilized as the working angle, and the Invo system was connected to both sides of the patient's forehead to continuously monitor the oxygen levels in the brain. 2 Hyperform 4x7 mm balloons were used. The tips of the Expedion wires used with these balloons were trimmed carefully into a J shape in order to avoid involvement of the perforating arteries. The 2 balloons were passed through Y-shaped connectors and attached to the 6 French shuttle sheath. Now for inserting the catheters. At first, we tried to insert the balloon with Expedion wire, but decided that it would be too difficult to continue with it, and removed Expedion, changing over to Ragifocus GT double-angle wire. Working with the particular characteristics of the Ragifocus wire, we guided the Hyperform balloon to the distal left A2 segment. When it was set sufficiently in the distal position, the Ragifocus wire was removed and replaced with Expedion again. Then, the balloon was firmly implanted in the neck of the aneurysm. Next, in the same manner, another Hyperform balloon was inserted, this time into the right A2 segment. Going through the anterior communicating artery, a Hyperform balloon with a micro guide wire was placed in the distal right A2 segment. Once again, Expedion was not suitable at first, so the Ragifocus GT double-angle wire was used to replace Expedion. after a hypoform was inserted into the right A2 segment using the Ragifocus GT double angle, it was changed to Expedion again. And a second hypoform was implanted in the neck of the aneurysm. When the two balloons are securely in place in the neck of the aneurysm, a microcatheter is inserted. In this case, an Excelsior SL10 90-degree catheter was used. When the microcatheter is in place in the aneurysm, the coil embolization procedure can begin. As the first coil, we selected a V-Track 18 compass 5mm 11cm coil. The balloons are in turn inflated and deflated repeatedly as the coils are firmly embedded in the aneurysm, all the while being especially careful that it does not slip out into the parent artery. When the coil is firmly in place, the balloons are deflated while making sure the coil does not move using the blank roadmap. It is then possible to detach the coil. As the second coil, an Orbit Galaxy 4mm 8cm coil was selected. At most, the balloons cut off the blood flow for less than 2 minutes at a time, and the INVO system was used to check the oxygen level in the brain for prevention of cerebral ischemia. Continuing with the coil embolization, the finishing coil used was an ED Extra Soft 2mm 2cm. The procedure was completed with a total of 6 coils, and the VER was at 37%. After the procedure, angiography showed sufficient embolization. The puncture point was then sutured using a Parclose instrument. The bleeding was completely stopped. The day after surgery, an MRI diffusion image revealed no complications, and the patient was discharged from the hospital on the third post-operative day.
With cerebral aneurysms, the double balloon assisted technique is used for cases with wide neck aneurysm because it helps preserve normal blood vessels and makes dense packing possible. In our experience, we have found that this technique can be used for wide neck aneurysms without regard to location. This has resulted in the fact that at our hospital, 3 cases of ACOM, 1 case of MCA, and 5 cases of BA were treated with this technique, in which 2 balloons and 1 catheter were inserted. Nevertheless, there were no complications, and post-operative diffusion image revealed only a small embolic lesion in 1 case. This shows that even with broad neck aneurysms, double balloon-assisted coil embolization is possible. Further study and careful long-term follow-up are of course necessary, but surely the role of interventional neuroradiology will grow in regard to the treatment of cerebral aneurysms.